Hi, my name is Dr. Jason Hochfelder. I'm an orthopedic surgeon with Hudson Valley Bone and Joint Surgeons and Phelps Memorial Hospital. Today we're going to go over a topic that I recently presented at Phelps Hospital called Protecting Your Joints as We Get Older and Keeping Them Healthy and Active. First, just a little bit about me. I originally grew up in Briarcliff Manor and then went to college at Johns Hopkins University in Baltimore, where I was a pre-med and a pitcher on the varsity baseball team. I then came back to New York City and did my medical school at NYU School of Medicine, and then did orthopedic surgery training for 5 years at NYU Hospital for Joint Diseases, also in the city. After that, I did a 1-year specialty training of hip and knee surgery at the Insall Scott Kelly Institute also at NYU. I tell everyone at this point that I do have a little bit of bias in this talk because although the talk is about protecting your joints and keeping them healthy, as an orthopedic surgeon, I actually do make a living on people whose joints are not healthy. The first thing we'll talk about is anatomy. Then we'll talk about the various conditions and reasons that your joints could be hurting you. Then we'll talk about ways that we can actually try to prevent these joints from hurting you. Unfortunately, though, it doesn't work for everyone, and then we'll talk about ways that we can treat these ailments conservatively. Then we'll move on to various different types of injections. And then unfortunately, sometimes surgery is involved in keeping people active and healthy. And just because you have surgery doesn't mean that you failed. Many of my patients who have surgery are able to return to active and healthy lifestyles. First thing we're talking about is anatomy. Anatomy is the most important thing that we're going to talk about. And that's why it's the first 6 months of any medical school curriculum, because in order to understand what the problems are, in order to understand how to treat them, we do need to understand a little bit about anatomy. First thing when you're talking about any joint is the bones. The hip is a ball in the socket joint, just as the shoulder is, which means it can move in multiple directions. And then the knee, as well as a lot of other joints, such as the ankle and all our fingers and toes, are what we call hinge joints, which means they can bend and straighten only. On the end of every bone in our joints is something called cartilage. I have this picture of a chicken wing up here because one of my great mentors, Dr. Norman Scott, who's actually one of the founding fathers of knee replacements, used to tell everyone that the way that you knew what cartilage was is if you look at the white shiny stuff at the end of a chicken bone, that's where your cartilage is. The cartilage really acts as a shock absorber. And when we start to talk about arthritis, which is one of the most common ailments that people suffer from as they get older, what that is it's actually a wearing away of this cartilage or this shock absorber on the end of our bones. Other pieces of cartilage in our joints, such as in our knee, is something called the meniscus, which is also another shock absorber and another piece of cartilage. Our shoulders and hips have things called the labrum, which are also pieces of cartilage and can sometimes be injured as well. Here in our knee, we were looking at, on the left side, various ligaments and tendons that we have. Ligaments are aspects of our body that connect one bone to another bone. And tendon, as you'll see in one of the future slides, is actually something that will connect a muscle to bone. So that's the one difference between a tendon and a ligament. And these can be strained, pulled, torn, or anywhere in between. And that will show you in a little bit of the future slides. Obviously, we have lots of muscles that cross people's joints. And these muscles can be pulled or strained or injured and become very inflamed. Every joint in our body has lots of muscles that cross it in the front, back, and even on the sides. And any one of these muscles can be pulled, and it's important to know where they are because where they hurt usually can correlate with where the actual problem is. A bursa is another important thing that we need to know about. Really what a bursa is a fluid-filled sac. And any bony prominence in our body, you can feel the outside of your hips, you can feel the tip of your elbows. We also have them in the front of our kneecaps and also in our shoulders. We have something called a bursa. Most people who know what a bursa is know what it is because they've suffered from something called a bursitis. That's when these fluid-filled sacs become inflamed and irritated. And there can be lots of reasons that this can happen. Sometimes it's due to being irritated or actually direct trauma. And sometimes it can be due to actually the muscles rubbing against it, or really maybe you're walking a little bit differently because of something completely differently up in your spine or in a joint nearby. Next, it's important to understand the nerve distributions in our body. This map here is actually telling us that every single nerve in our body goes to a different area. And all these nerves are started out in our spine. So you can see up in your shoulder, if you look by the shoulder joint in this picture, there's something called the C5, which means the fifth cervical nerve, and even the C6 if you look on the right towards the back. What that means is that if you have a problem in one of these nerves in your spine, you might not necessarily feel it in your spine, but you actually would probably feel it in your shoulder. So having pain in your shoulder joint doesn't necessarily mean that there's a problem in your shoulder. It may be coming from your back. If you look down on the bottom towards this person's legs, especially on the left side where they're facing forward, you'll see my favorite nerve, which is the L4 nerve. The L4 nerve is so important because as a hip and knee surgeon, you can see that it runs across your hip joint and also across your knee joint. And in fact, this nerve, the L4 nerve, is actually the most common nerve that's irritated and is actually one of the nerves that makes up the sciatic nerve. Everyone mostly that's listening to this talk probably has heard of the sciatic nerve and knows about sciatica. But the sciatic nerve is actually made of multiple different nerves, and depending on which part of that nerve is irritated, you may feel pain or discomfort in a different area. So as a knee surgeon, I often will see people who have this L4 nerve being irritated, and they're coming in complaining of pain over their knee joint, but it's actually not the knee that's involved at all. It's actually the L4 nerve being irritated up in the spine. So this chart here is very important to realize and to pay attention to, because a lot of patients who have pain in one area may be coming from another area. So that's it for anatomy. Now we're going to talk a little bit about the various conditions and the various problems that can occur to all these different areas that we just talked about. These are just a little bit of a preview of what the topics we're going to talk about. Arthritis is usually the most common one and usually the number one thing that ails people, especially as their joints get older and they start to wear them out. Cartilage tears are really a spectrum of arthritis, and when you have a little bit of tear in cartilage, it can be treated in isolation. But when arthritis, which is generalized cartilage wear, sets in, the treatment becomes a little bit different. Bursitis we talked about briefly before, saying that it's actually when one of those bursa becomes irritated. A tendon, if you remember, is something that connects a muscle to a bone, and that can sometimes become irritated, and that's called tendinitis. A sprain and a ligament tear is really just the same spectrum of one disease. And as that starts to progress, you can go from a sprain, which is really just a minor tear, to a more severe tear, which we actually call a tear. Stress fractures are very important to understand, and these have two different types. There's a type of stress fracture that occurs in athletes, and then there's a type of stress fracture that occurs in patients as they get older and their bones get weaker and the bone sort of fails. And then the back, obviously, we talked about that when we looked at the nerve distributions, how the back can actually affect our joints. And then there's something called referred pain, which is similar to the back, where you can have a problem in one area and you'll actually feel it in the other area. Arthritis is probably the topic that most people listening to this talk are concerned about, and most people want to know about, and most people suffer from. It's important to realize that there's actually 3 different types of arthritis. While the end result is generally the same, how you get there sometimes is different. And if you remember, arthritis is generalized wearing of that cartilage, that white shiny stuff on the end of our bones. As that wears away, it becomes painful and stiff and really uncomfortable. A lot of patients, what they don't realize is they think that arthritis is something that's there that we can go in and take out. And actually, if you look at the slide, especially on the left where you see the cartilage being worn away, arthritis is not actually a thing that's there. It's actually the absence of something. It's the absence of that cushioning. It's the absence of that cartilage. So these are the 3 most common types. It's osteoarthritis, which is really the most common type, which is really just a generalized wear and tear, can occur from overuse, from patients being overweight, or sometimes we're born with our legs in a certain position that causes one area of our leg or knee joint, or even our hips or shoulders to wear out over time. In the middle, you see something called post-traumatic arthritis. This occurs when patients have injured a joint, especially an injury that goes through the actual joint surface itself, meaning that cartilage has been injured. Once the cartilage is injured, it's very hard for that cartilage to heal, and it can go on to degenerate even further, and that's called post-traumatic arthritis. Inflammatory arthritis are diseases called rheumatoid arthritis or psoriasis, where our body's own immune system will actually attack our own joints. This used to be a lot more common in terms of what we saw as orthopedic surgeons, but now most patients have seen commercials for medications on TV like Enbrel, which is a common one, that are very, very good at actually preventing our immune system from attacking our joints. So while the actual disease is common, the results of it and the end stages of it are not quite as common since we have all these new medications to treat them. Cartilage tears, as we talked about before, there's different types of cartilage in our body. There's the labrum in our shoulder and our hip, and there's the meniscus in our knee joints. When these are torn in isolation, they can be treated by themselves, either with therapy or sometimes with surgery. But it is important to distinguish what I call a focal cartilage tear, which was what we're talking about here, which is when the rest of the joint is fully healthy and then there's just a small little tear. And then generalized cartilage tears, which is what arthritis is. When you have arthritis and all the cartilage is torn and you also have a meniscus tear in your knee, or you also have a labrum tear in your shoulder or in your hip, then this needs to be treated as arthritis. When the rest of the joint is healthy and you have an isolated tear of one of these smaller pieces of cartilage, this can be treated in isolation. So it's very important to realize I have patients every single day in my office that come in who have severe arthritis, and they come in with an MRI that shows that they have a meniscus tear or a tear in the shoulder. And I tell them that that MRI for the most part was actually useless. That's not to say that every MRI is useless, and that's usually for me to determine. But a lot of times when you have a meniscus tear, it's really just a spectrum of arthritis. So it's really important to distinguish between the two. A Baker's cyst, this is really something that I just wanted to include specifically. Not everyone really knows what it is and what the treatments are. A Baker's cyst is a fluid-filled sac in your knee. Usually it's in the back of the knee, and you can see it here on the left. On the right picture, you can see all the important nerves and arteries in our body, and you realize that this is why it's so difficult to treat a Baker's cyst. You can't just go in and stick a needle back there because you risk injuring a lot of these nerves and arteries. Same thing with surgery. In order to go back in there and take a Baker's cyst out, you need to get by all these nerves and arteries, and the surgery becomes very dangerous. The reason that Baker's cysts occur is usually because there's an injury somewhere else in the knee. Oftentimes it's arthritis, sometimes it's a meniscus tear, and sometimes it's a cartilage defect that we talked about. If you have one of those problems and you only treat the cyst alone, you've really not treated the root and cause of the problem. So it's important to realize that although you may have an MRI or an ultrasound, or someone may have told you that you have a Baker's cyst, that's really a result of what the problem is, and just treating it alone can be A, dangerous, and B, not get rid of the full problem. Bursitis, we talked about that before. What that means is that some of these fluid-filled sacs in our body can become irritated. On the top right, you see the bursa in our shoulder, which is a very common one that gets irritated. The outside of the hip joint is a very common one as well. Speaking of which, it's important to realize that you can see the hip joint itself is actually more towards the groin, and actually the bursa is actually towards the outside of the hip. So a lot of patients come into my office and say they're having problems in their hip joint, and they point towards the outside of their hip, and that's usually a bursitis or a tendinitis, and usually a pain towards or into the groin is often more indicative of a problem in the actual hip joint itself. You can see in the knee on the left, you can have a bursitis above your kneecap or right in front of it, or even below it, something called a pes bursitis, and that's where some of the tendons come in, and you have actually a bursa down there as well. We talked about before, sprains and strains and tears of ligaments usually occur from injuries and not usually from overuse themselves, which a bursitis or a tendinitis will occur from. A sprain usually is from an acute injury. A grade 1 sprain just means a few of the fibers of that ligament tore, and then actually a full-on complete tear is usually a grade 3 sprain, and that just means that it was completely torn. And grade 1 is usually treated very conservatively, and only very, very rarely when it's completely torn does surgery actually required. A stress fracture we talked about. On the left, you can see an actual real fracture, and that's usually in younger athletes, military recruits, people who are training for the marathon. These are people who are overdoing it. On the right, you can actually see someone who's got pretty significant arthritis. You can see the bone is a little bit whiter and thinner, and that person has weak weaker bone, probably from having some degree of osteoporosis. And then also the cartilage, the shock absorbers have worn away as well. So if someone overdoes it, or sometimes we don't know why, if the bone is weak and there's not a good cushioning, you can actually get a stress fracture, not necessarily from overworking, but just from having weaker bone and less cushioning on top of it. These two are treated very differently. Usually an insufficiency fracture is treated very conservatively, resting, icing, usually sometimes just taking some weight off it, and stress fractures in athletes are treated far differently and often and sometimes require surgery. Back problem, we talked about this before, how it's very important. You can see again, I included what we call the dermatomes on the right, which is where a nerve is injured, or meaning where a nerve travels to. On the left, you can see a depiction of a herniated disc where a fluid-filled sac is actually pushing out onto the disc. And you might not necessarily feel pain there, but you'll feel pain where that yellow thing, the nerve, is actually traveling to. And you can just see on the right a little bit of a description of where the nerves actually travel to. And then lastly, we just mentioned referred pain. This is very common sometimes in people who have hip problems. They may have a problem in their hip joint and actually feel pain in their knee, and this is not actually very uncommon. And in fact, actually happened to my grandmother, who had a terrible arthritis in her hip, came to her doctor many years ago complaining of knee pain, and ultimately it ended up being that her hip was the problem and she had a hip replacement, and it solved all her knee pain problems. It doesn't only happen from the hip to the knee, but this is the most common one. So where you actually are having the pain doesn't always correlate with where you're having the problem. And so it's important when you go to see a doctor that they not only examine the joint that's the problem, but also examine the joint that are nearby, just to make sure that there's nothing in terms of the referred pain spectrum. Now we're going to talk about prevention. This is why most of you are listening, and this is what most of you want to know. How can I prevent these problems and ailments, and how can I prevent from getting to the problem or the thing that we're going to talk about at the very end, which is surgery. This is the most important slide of this entire talk. I tell everyone I could spend all day on it, and this is what I tell all my patients. You really, in order to protect your joints, especially your joints in your lower legs, you want to do low impact activities. Low impact activities involve bike riding. It doesn't have to be the stationary bike, swimming, and then also this machine that I call the cross trainer, or sometimes called the elliptical trainer. You can see in all of these exercises, your joints are not constantly pounding, your foot is left planted, and it puts very little stress on your joints. Every step you take, every time you jump, every time you run, it puts 5 times your body's weight onto your joints. And so if you want to prevent them from wearing out and overdoing it, you'll actually want to do a lot of these activities. In terms of the bike, it's very important that you actually don't put the bike too low. What that means is you have the seat elevated. This prevents your knee from bending too deep and prevents your hip from bending too deep. Because when you bend them very far, you realize that that's actually the position that irritates them the most. Anyone who's been to my office knows that I bend your knee very deep and see if that bothers you, because usually that's the position that puts the most stress on that joint. Swimming can be good. Sometimes it can irritate people's shoulders. If that's the case, obviously we're going to all use common sense, and any activity that bothers us, we're not going to do. A lot of people ask me about walking. Walking is very important because in preventing osteoporosis, which is a weakening of our bones, it's very important to do some impact activities. But as I mentioned from the previous slide, avoiding high impact activities is important. So walking is a low impact activity. It does involve some cardiovascular exercise, which is good as well. But it is important that when you do it, that you put very comfortable shoes with very thick pads, and you want to walk not like these people are doing on a concrete surface, but actually on a soft surface like a track or on grass, in order to actually prevent all that shock and that impact from traveling up to your other joints. A lot of patients ask about golf. Golf is a very important activity, especially as we get older, because it allows us to be outside, it allows us to socialize, and we don't think of it as a very stressful, severe exercise activity. But just keep in mind that as we twist and as we turn, that a lot of stress does go into our joints. So just as with everything that we're going to talk about, use common sense. If something hurts you, then try to avoid it. What I listed right here in terms of the letters on the page, you can see I wrote AAOS, that stands for American Academy of Orthopedic Surgeons, Conditioning Program. These are all good exercises to do if you go to this website, which is the American Academy of Orthopedic Surgeons, and you can just type it in just as I've written right here on this slide. And what you can do is after AAOS, you can actually write whichever body part seems to concern you the most. You can write knee, you can write hip, you can write shoulder, you can write back. Just for example, you can write AAOS hip conditioning program, and this will take you to a website that will have a great exercise program for you, and especially for that joint that's recommended by the American Academy of Orthopedic Surgeons. But just as I mentioned before, use common sense. If any of these exercises bother you, cross them out and do not do them. Shoes are very important. This is just a random picture that I got off the internet. I tell everyone I do not have any specific interest in this shoe label. I don't know what type of shoe this is. I don't know this brand, but the important thing to realize is that this shoe does have good cushioning. Anytime we take a step, every time we jump, all the shock that goes through that travels through our shoe first. So if you have good cushioning in your shoes, then that will help prevent a lot of that stress going through the rest of your joints. Range of motion, very important, especially when we're talking about our knees and our shoulders. You can see here 0 means fully straight, 90 means bent at a right angle when we're talking about the knee. You want to try to do activities that don't involve bending past 90 degrees and also involve not locking your leg out fully straight. These are the positions that put the most stress on our joints. So 0 to 90 is what I tell everyone. You can do things like leg press exercises, you can do leg extensions, but just make sure you're not bending your knee all the way deep, just as we talked about with the bike. And shoulder exercises, there's very few activities that we need to do in terms of exercise where we put our arm above 90 degrees. A lot of people ask about swimming and tennis and things like that. And obviously everything comes in moderation, but there's very few exercises that you need to do that involve raising your arm above. You have rotator cuff muscles between your shoulder and between your shoulder blade, and when you put your arm above your head, you actually will pinch that rotator cuff muscle between your shoulder and your shoulder blade, and it can cause it to become irritated. Weight loss, obviously everyone knows the answer to this, but as I tell people, just because you know it doesn't mean you're going to do it. And sometimes just hearing it from a doctor is actually the most important thing. So I'm a doctor and I'm telling you, maintaining an appropriate body weight will help your joints. And if it doesn't, or if it doesn't get rid of any of the pain that you have and you end up needing surgery in the future, your surgery will be a lot easier and your recovery will be a lot faster. So in reality, there's really no downside to maintaining an appropriate body weight. Lastly, in terms of prevention, don't throw away the cane. If you can look here, cane should be with your arm rested at its side. Most people, a lot of my patients who need a cane or tell me they would benefit from a cane do not like the way it looks. But I tell most patients, well, you won't like the way it looks if you trip and you fall and you end up in the hospital with a broken hip or a broken ankle. So a cane can be very important, and it's important to realize that a cane goes in the opposite hand of the hand that's the problem. If you're having a problem on your right side, you put the cane in your left hand and then vice versa. What this allows you to do is actually lean away from the side that there's a problem and takes pressure off of that side, which is really the goal and the main purpose of using a cane. Now we're going to talk briefly about some conservative treatments. Obviously, hopefully we've avoided needing them, but these are what we can do. These are a lot of the ones that we talk about: rest, ice, heat, braces, elevation, and medications. Ice and heat. Ice is good for inflammation, usually good for our joints, shoulders, elbows, knees, and hips. When we have something that's called inflammation, which means that area is very irritated or inflamed or swollen, then sometimes heat can be good for that in terms of muscles. Heat's good for getting rid of muscle soreness, tendons, ligaments when they're really tight and stiff. But when they get very inflamed and you have a bursitis or a tendinitis, really anything that ends in itis means inflammation, ice is usually good. I tell most patients no more than 30 minutes at a time, because then you run the risk of getting frostbite, and then you want to give yourself a break for 30 minutes. So 30 minutes on and then 30 minutes off. And that's the same for heat as well. In terms of braces, these are a lot of the common ones that people come into my office with for their knee. All the way on the left, that one is very specific in terms of a patella, which is the tendon that's between your kneecap and your shin bone, patella tendinitis. The next one, the one with the cutout for the kneecap, is a very important one. It's one that patients use all the time. There's lots of different ones. I usually don't tell them that one is better than the other. A lot of times it's trial and error. the most important thing is that you do have a cutout for the kneecap, and this allows the kneecap not to be pushed against the thigh bone, because that can actually cause more damage than good. So make sure that if you get one of these braces, it has a cutout. It really doesn't do anything structural. Mostly the goal for this brace is just to provide some gentle compression and provide a little bit of pain relief. The next two braces, this one here with the B on it, with the hinges on the side, that's usually a very specific brace that's used for an unstable knee after some sort of injury or some sort of surgery. For most general ailments, arthritis and tendinitis and things like that, it's a little bit of overkill and a little bit of a waste of money. And then the one all the way on the right is very specific. It's called an unloader brace. If you have arthritis in one area of the knee only, it can actually cause some pressure on the knee joint and actually relieve that stress. It can be a little bit uncomfortable, and usually we'll only use this brace in patients who are considering doing a partial knee replacement on, almost as a trial, just to see what it would feel like if that one specific area of their joint was unloaded. Elevation, if you have an acute injury or acute swelling, elevation is important. It helps get the swelling down, because swelling is like water and water runs downhill. So it's important to make sure that when you elevate a joint, you elevate it above the level of your heart, and that allows the water or the swelling to run away. Medications, obviously you always want to check with your doctor. Everyone, especially as we get older, starts to be on more and more medications, have more medical issues. So it's important to check with your doctor before starting any new medications. But it's important also to realize that a lot of patients that I see have under-medicated themselves. NSAIDs, which are anti-inflammatory medications, are usually excreted out through our kidneys and work on inflammation. Tylenol is usually gotten out of our body through our kidney and is really a pain medication. So as in generally healthy patients who have no contraindications, you can actually take an NSAID, which is an anti-inflammatory. So one of these medications from the top, which is Advil, Aleve, Mobic, diclofenac, or Celebrex, and you can actually combine one of those with Tylenol. Or you can alternate, but like I said, they work differently in different ways, and they actually get processed by our body differently. So oftentimes we can actually combine some sort of anti-inflammatory pill with Tylenol. Now, I always take a little bit of a pause, because really everything that I've talked about before and everything that I'm going to talk about after has a lot of research and a lot of science behind it. But it is important to realize that there's a lot of treatments out there that people do and take and that work sometimes that don't have a great lot of science behind them. But my job today is not just to tell you everything that has science behind it, but it's to tell you everything that exists and all the possible things that people are doing. Today we're going to talk a little bit about the supplements that are out there. It's important to note that every single thing on this list either has no or very low quality research supporting its use in terms of alleviating pain in our joints. The first one I'll talk about a little bit, which is glucosamine and chondroitin, is a very common one that people take. This is not regulated by the FDA, and most of these combinations of these pills that you get at the drugstore and over the counter actually sometimes have a little bit of anti-inflammatory medication in them, and a lot of times this is why they'll actually be effective. But what really high quality research studies that we have actually tell us that glucosamine and chondroitin pills, compared to a placebo, which is really a sugar pill, actually have no effect. These other ones, apple cider vinegar, green tea, citrus fruits, extra virgin olive oil, tart cherry juice, omega-3 acids, and so forth, and many more, have all been implicated to have certain things in them that have anti-inflammatory processes and that can actually help our joints. But just to let you know that the research behind it is not really there. So a lot of them are safe and healthy. I think the most important thing that you can take from this slide is that you should have a very healthy, well-rounded diet, because almost anything that you can study, some people have said will have some effect and benefit on your joints. So I think if you have a well-rounded diet, keep your weight down, that's the most important thing that I think you should be putting into your body. If preventing it didn't work, if the conservative treatments haven't worked, what types of injections are there? Cortisone shots are probably the most common thing that we do, especially as an orthopedic surgeon. I give cortisone shots every single day. Really, cortisone is an anti-inflammatory molecule that's actually made by our body. It comes in forms that were processed and manufactured, but we actually inject them in many different areas. Sometimes we inject them into tendons that are inflamed, ligaments that are inflamed, and very often into joints that are inflamed. A lot of patients ask me, can you get too much cortisone? And that's not an easy question because the answer is yes and no. Cortisone can degrade some things in our body. It can weaken our tendons and our ligaments. So when I'm talking about giving cortisone into tendons and ligaments, yes, I think that it probably should not be given overly often because those tendons and ligaments can actually weaken and in the worst case scenario, snap and actually take a problem that's not so bad and make it a lot worse. When we're talking about injecting cortisone into our joints, there have been some research that talks about whether the cortisone can actually weaken the cartilage and the bone around the joint. And my response to this is this. If you have a worn out joint and your only hope is either cortisone shots or surgery, well, if you have a cortisone shot and it's going to disrupt or degenerate the joint a little bit more and you're going to need surgery, well, you would have needed surgery anyway. So I really don't think that you can overdo it in terms of cortisone. Some of it does get absorbed in your body, so I wouldn't inject it into a joint more than every 3 months. A lot of times after a while, the damage sometimes gets worse and people end up needing surgery. But as an alternative to surgery, as long as it's not given too often, I don't think that there's any major downsides to it. But just once again, it's important to realize that cortisone decreases the inflammation. When we're talking about joints, it doesn't necessarily get rid of the problem, but it gets rid of the symptoms of the problem. Hyaluronic acid, which is another material that's found in cartilage, sometimes is injected to our joints. It's like a lubricant. I tell people it's almost like changing the oil in our car. If you have an oil change in a car, it doesn't do anything to the engine or the wheels and so forth. So same thing, it can help, but it doesn't necessarily solve the problem. And most commonly it's given to knees, but sometimes it's been given into hips as well. The next two topics, the plasma and the growth factors, really can be combined into one. The idea behind these two injections are that it's going to take some of our body's own growth factors and inject them into a joint to try to heal some of the damage. Sometimes we do inject them into ligaments and tendons as well if they're torn or partially torn to try to use our body's own growth factors to heal some of the damage. The science behind it is relatively new. And also, these shots are usually not covered by most people's insurance. What that means is that a lot of the research done behind it is done by doctors who make a lot of money off of doing them. So you do need to take everything that you hear and all the research behind it with a grain of salt. But a lot of it has been shown in some recent studies to be effective, but to what degree I think is to be determined. The stem cells are similar to the plasma injections, except that they actually have cells in them. There's lots of different preparations, there's lots of different types, which makes it very difficult to study. Sometimes it can be given from amniotic fluid, sometimes they're derived from our own bone marrow or stem cells or from our fat. And there's a lot of claims out there, but I think same thing. The more severe and more worn away the problem is, the less effective these shots tend to be. And so in my mind, they're really, for most people, a last-ditch effort to try to avoid surgery, or even in patients who sometimes have medical issues that make them not good candidates for surgery. So I do think it's important that you should consider these sometimes, but it is important that you take into account, A, that it's not covered by insurance for most people, and B, that the research behind it is a little bit weak. So as long as you understand those two things, for some patients it's not a terrible choice. Now we'll talk a little bit about surgery. Like I said, I'm a surgeon, and so I do have a little bit of bias here. But for some patients who they haven't been able to prevent the problems, conservative treatments and injections don't work, surgery can sometimes be the best way to get you back on your feet and get you back doing what you want to do again. The most common surgery that's done nowadays on people's joints is an arthroscopy, very commonly done in the knee joint for a meniscus tear. If you look at the knee on the left and the knee on the right, and I tell everyone neither of these are my patients, you can look at the top of the joint and you can see on the left side that it's completely worn away, and that in addition to the meniscus tear, which is in the middle, where the probe is pointing to, you also have arthritis, because that means that that cartilage is all worn away and you can see it falling off the top of the joint. So in this patient, they have arthritis and a meniscus tear. So this arthroscopic surgery that's being performed by whichever doctor this is that I found it on the internet from is probably not going to get better. There's a lot of research out there, and in fact I always reference people to the 2016 New York Times article in August called Why is Useless Surgery Still Done? And in addition to certain back surgeries, it talks about arthroscopic meniscus surgery for people who have arthritis. So in this case, the arthroscopic surgery is really not meant to treat arthritis. It's only meant to treat a meniscus tear, which is fine for the patient on the right-hand side, where you can see a nice shiny surface on the top and on the bottom, and the only problem being the meniscus tear. So arthroscopic surgery, while sometimes can be effective for meniscus tears, is not the right treatment for patients who have both a meniscus tear and arthritis. On the bottom, you can see arthroscopic surgery done for shoulders. This can be done also for hips to treat labrum tears, tendon tears, and ligament tears, and sometimes, in fact, to relieve a bursitis, but very rarely. For more extreme examples, especially in cases of arthritis, we talk about joint replacements. Hips, knees, and shoulders can all be replaced. Generally, with shoulders and hips, we're talking about full replacements, and partial replacements don't really have a role. And then on the left side, you can see me talking about for the knee. The knee does have three areas: the inside, the outside, and the area under the kneecap. And when one of these is only involved and the others aren't, sometimes we'll do something called a partial knee replacement, which you can see of the knee picture is the one on the right. And when all three areas are involved, there is something called a total knee replacement, where the whole knee is replaced. In terms of the recovery between these two operations, generally partial knee replacement is a little bit faster, but I wouldn't tell you it's that extreme a difference. And obviously the one downside to a partial knee replacement is that if only one area of the knee is replaced, the rest of it may wear out over time and you may need another operation. So a total knee replacement compared to a partial does have a lower rate of reoperation. The whole talk is about keeping active after, in your lifetime, and this I always put up as a little bit of a helpless plug for myself. This is actually one of my patients. This is not a picture from the internet. This is a picture that one of my patients sent me less than 1 year after he had his hip replaced. And so here a little bit of my bias does come in, where I tell you that sometimes it is actually surgery that involves keeping us active and keeping our joints feeling good and healthy. So although the goal for a lot of patients, and I understand it, is to avoid surgery, sometimes surgery can be a life-changing thing, and it certainly was for my patient here. Here's just a few websites that I refer people to. I mentioned the American Academy of Orthopedic Surgeons website, which I think is really useful. It has information on everything, and it has those great work exercise programs that I talked about before. The Arthritis Foundation has a great website, and then the last one is the American Academy of Hip and Knee Surgeons. I really want to thank everyone for joining us and listening in, and I hope you have a great day. And here's some of my contact information if you ever want to come and talk and learn a little bit more about a lot of these options and prevention and treatment.